Okay, I want to welcome you to the second part and the keynote address for our Yale International Fox Fellows seminar workshop on training leaders for the 21st century. As I said before, the Fox Fellowship was created 27 years ago now as an exchange program between Yale and now 18 partners, in which we bring students from the 18 partners to Yale for a year, and then Yale sends out students to our partners to engage in both collaborative scholarship, but also the practice of critically important global challenges. And this seminar on leadership is part of a broader year-long effort organized by Gilad Abiri. Gilad, can you put up your hand again? Thank you. There's Gilad. Okay. Recognize you again. Yes. And also the program is administered by Julia Moravnik. Where's Julia? Julia? Okay, now, and we've had already seminars on environment and leadership, corporate social responsibility and leadership, and recently in India on the role of the BRICS countries. And today we have a really important question about the role of U.S. healthcare. And I'm going to introduce our moderator, who will introduce our keynote speaker. And so our moderator is Jacob Hacker. And before I do that, by the way, I want to emphasize that this is co-sponsored, this event, with the institution that Jacob heads up, Institution for Social and Policy Studies, as well as the Global Health Justice Partnership that is a joint program between Yale Law School and Yale School of Public Health. So, Jacob, can't say enough in just a few minutes, but so I'm going to read from part of his bio. But he is the Stanley Resor Professor of Political Science and Director of the Institution for Social and Policy Studies, and is both an academic as well as a media commentator. He's often on National Public Radio, the only good radio in America is NPR. And oftentimes I'll hear Jacob speaking and be like, good point, and I'll start talking to him when I'm in my car because he's making such important points about how to link really important scholarship to public policy questions. And I won't read his entire bio because it is so long and illustrious, but I do want to say that he wrote a really important book that asked the question, why is it that the United States does not have universal health care when so many other Western industrialized countries do? I think actually all others. Is that right? Almost?
At this point, yeah.
Almost? Okay.
Yeah, Switzerland was kind of lagging, but it moved into the
okay.
advanced industrial pact.
Okay, so it's come in. So as a Canadian, this is a very curious question too. And he looked at the research that looked at political culture, public opinion, and he said actually what happened was a very small choice about 90 years ago that gave tax advantages to the provision of private insurance that then had path-dependent effects over time that led to and created an institutionalized system that made it difficult for Hillary Clinton to bring in universal health care in the 1990s. And as a result, from that work, and it's a wonderful read, I think it's like 600 pages. Yeah, but each page is thrilling. I couldn't put it down. From that careful analysis, he says, you know what? If you're going to fight fire, you got to fight fire with fire. And can you actually apply path dependency in a way to trigger then what might become universal health care? And that is the reason why he is the creator and promoter of what was known as the public option. And a great example of linking top-shelf scholarship to practice in really important ways. And so with that brief introduction, I welcome Jacob Hacker.
Thank you. Well, it's a pleasure, and Ben is funny because he's the only person that says it's a great 600-page read. And not only this book, but in general, right? So I am very pleased to be up here, and it is true that I've written a lot about health policy. Also, more recently, I've been writing about the way in which government and the private sector evolved together in the United States, and in particular, the way in which people who moved between the private sector and government, people who were part and parcel of the mixed economy of the United States in the mid-20th century, are really central to creating the prosperous society we have today. And that's, I think, a pretty good introduction to Kevin Counihan, because in an earlier generation, he would have been seen as the archetype of this mixed economy Mandarin, someone who has worked in the private sector, in the Tufts Health Plan, in the Choice private insurance exchange in Massachusetts, but also who has worked in the public sector in interactions with the private sector, both in Massachusetts. He was there at the beginning with the Commonwealth Connector that was an outgrowth of the Romney Care Plan that defined the debate at the national level, and a few years later. And then, of course, he was also involved in Connecticut's insurance exchange, which was the most successful in the nation. In fact, a few years back, we had Kevin here, and we had an event which was entitled Ready to Launch. Now, unfortunately, this event happened just before the website launched, which was not the most auspicious beginning. The wonderful thing was that we were talking about the Affordable Care Act in Connecticut. And so even before the federal exchange website problems were worked out, and they were worked out, Connecticut was rocking the Affordable Care Act. And not surprisingly, Kevin was tapped to move up to the national level and play a leadership role there, where he's CEO at the Center for Medicare and Medicaid Services. Basically, he's been the point person on the federal insurance exchange. And I just want to say a couple quick things before I introduce him, because this is such an important moment in the discussion of health policy in the United States. I mean, we've been having this debate, as I've written, roughly every 15 years since the early 20th century. And the fateful moment wasn't actually the tax breaks for health insurance or the War Labor Board decision to encourage private benefits, or the fact that unions and the AMA found themselves agreeing on the value of private insurance because government wasn't acting. It was actually FDR's decision not to include a health insurance provision in the Social Security Act in the 1930s. And so if you think about the seminal moment of American social welfare policy, this was a moment when we very likely could have seen a decisive move in the direction that other countries took. If you think about that moment, we basically missed the opportunity, and we came to rely heavily on a private, much more private system than other countries. And then every 15 years we had this debate. Occasionally we managed to add on gap-filling public programs, vital programs like in 1965, Medicare and Medicaid, but not until the Affordable Care Act passed in 2010 by the skin of its teeth did we see a move to create a program that would provide insurance to workers, middle-income workers, and those who are above the poverty line, that would be able to fill the gaps which were growing that our crumbling employment-based system had left. And so it was a fateful and crucial moment. It was as close as any debate could be. My baby, the public option, was sacrificed on the altar of political expediency to pass this law. And precisely because it is so hard to do this in the United States, because people have their own coverage, because we have such a costly medical system, this law was never overwhelmingly popular. It sat in a kind of limbo. There was no constructive measures to make it work better. Republicans who had supported similar proposals in the past, including in Massachusetts, decided strategically to be against it. It became a central plank of their policy vision. And that leaves, and had Hillary Clinton been elected, as many thought would happen, we would not be having this discussion, right? The Affordable Care Act would be finally, I think, being cemented in place, and there would be, as there has been with President Obama leaving office, a swing of Americans behind it. And we would have done the vital task of taking the starter home and building the next edition, building the foundation, and maybe someday that wing that I wanted to add on, the public option, would be built. But that's not the debate we're having. And I just don't think you can overstate the importance of the debate we're having. So I don't want to take up any more time, but I just want to say that Kevin comes here at such a vital moment, and he's played such an important role. And I think it's common for us to say something like, here is a person who has devoted his life to a goal that many of us share, namely making this public-private system work for ordinary Americans. It's common to say that, but in this case, it's true. And I want all of you to recognize just how valuable the work Kevin is doing is and how important what he's going to say today is. So thanks very much for having me, and thank you, Kevin, for coming.
Thanks so much, Jacob, for that. I have to say, I'm going to put a plug in for his book, too. When I think about the 5 most influential books that I've read on healthcare and healthcare policy over the years, that's one of them. So I would strongly recommend you guys getting that. First, I want to thank everyone from the Fox International Fellows Program for the invitation to speak here. It's a real honor. It's also a real honor to be part of the program with the other Fox Fellows who did such a great job. And thank you for that. It's also a great pleasure to be back at Yale and back in Connecticut. When about 2.5 years ago, when I first got to Washington, and we had a meeting with the president, and he got a few of us together, and he said he had a little message for us. And his message was, don't screw this up. He actually used a different word, but I think you get the idea. That's a similar bit of advice that my wife gave me about this speech, so I'm going to do my best to try to adhere to that tradition for both. As has just been said very well, there's been much discussion, of course, and debate about the Affordable Care Act and its future of health reform in the U.S. This debate is both understandable and it's also confusing and challenging to explain. It's understandable because the ACA, as has been said, has been controversial from its inception, and in particular because the enabling legislation to establish it, as Jacob said, was not passed with one Republican vote. So from the beginning, there's been this bifurcation, and the Republicans, almost from inception, have said that they want to repeal it immediately. It's confusing, of course, because healthcare, our healthcare system, by definition, is very complicated and very confusing. And in some respects, the Affordable Care Act has taken one of the most complex healthcare systems in the country, in the world, and actually doubled its complexity. One of the areas that a couple of us tried to work on was to actually try to simplify it from a regulatory perspective, and I don't think we were as successful as we wanted to be. So much of it, of course, is statutory, so that, of course, requires Congress to actually make those changes. There are some regulatory flexibility, but we did what we could, but it didn't always work as well as we'd like. It's challenging, too, in particular because we have yet to answer this fundamental question of whether access to health care is a right of citizenship or is it part of personal responsibility. And typically when you speak to Republicans, and I want to just qualify what I'm saying, I've been in the Obama administration. I just left on the 20th, Inauguration Day. But I am not a registered Democrat or a registered Republican. I'm actually an independent. But I say that because I don't want my comments to come through as being partisan in any way. I do have to say that having spent 2.5 years observing and working with the president a bit, I have just incredible respect and admiration for him. He's a pretty hard guy to dislike. He's got very good instincts. He even has good marketing instincts for a constitutional law professor. And I think we all learned a lot from him. So if that comes through, I apologize. I qualify that because it's not meant to be partisan. But in speaking to the Republicans, and we were talking a little bit earlier about working with moderate Republicans, it is very difficult just because the atmosphere is so challenging. On the other hand, the atmosphere is also kind of just bizarre. For example, like several of us, I had to appear before the House Oversight Committee several times, and that group can be a little bit tough, and so my first time, one guy there called me a liar. Another guy said I belonged in jail. A third guy reminded me 5 times that I was under oath, which was helpful because you forget that on occasion. And one guy said I was violating Sarbanes-Oxley, which I don't think applied to the Affordable Care Act, but it was good to know that was a violation. But the guy that called me the liar, that was the toughest on me, he called me 2 days before I left to ask if I wanted to use him for a reference. So for a job. So you just never know how things play out. This divide really is very, very complicated. It is very, very ideological. We were talking earlier about even how the polling worked. So during Obama's tenure, the Affordable Care Act polled 10 points higher than Obamacare. So just by definition, in a name, I think some of you may know that 1/3 of the country did not know that those two were the same. And it's interestingly because, from a marketing perspective, Obamacare is terrible. And by the way, all the people for which care is named after hate that. Romney hated Romney Care. Clinton hated Clinton Care. Obama said he loved Obamacare. He didn't. None of them like that because it sounds a little trivial and trite. So, but now I hear people saying, I bought ACA. A year or two ago when we were touring in the South, we tried to get onto the road as much as possible. We were going through southern states, and the brokers in the South would tell us that, in fact, they would go to their clients and say, would you like Obamacare or affordable coverage? And almost, not always, but almost uniformly, the clients would say, no, I don't want that Obamacare, but get me the affordable coverage. So even just from a marketing perspective, it's a very, very sort of bizarre situation. So the purpose of this talk is really to do a couple of things. One is to establish some context as to sort of where we got where we are. And it sort of builds off in part of what Jacob is saying. The second is to talk about the context for the Affordable Care Act. Speaking about health reform in Massachusetts, moving a little bit into Connecticut, talking then again about what the open enrollment period was. I came in, as Jacob had said, in the second year, in part because the first year didn't work the way it ought to be. It shouldn't have gone that way, but that's the way things go. I am more of an operations person than a policy person, so you're going to hear some operations kinds of things in this talk, and I apologize for that. I've always considered myself more of a business person that's applying business principles to a public sector mission. And that's, from a leadership perspective, that's really been the strategy. That was the strategy in Massachusetts, it was the strategy in Connecticut, and it was the strategy now at Healthcare.Gov. And I think to greater or lesser degrees it worked most of the time, in part because it was just a very practical approach. This is no criticism, by the way, of federal employees or state workers who are among the smartest, most competent and dedicated people I've ever worked with. It's just a way of doing things. There was an article in Foreign Affairs magazine about, I guess 3 years ago, that pointed out that only 6% of government IT projects succeed. And I think there's a reason for that. And at the risk of oversimplifying, it's in part because of, I think, of leadership. So anyway, just keep that context in mind, if you would. So, as Jacob had talked about, the U.S. is sort of an interesting, I guess, approach to how healthcare can be provided. It feels, and I'd be very interested during the Q&A to get everyone's reaction to this, it feels that where we may be migrating in looking at the proposals coming out under the repeal and replace is moving from guaranteed coverage to guaranteed access. And it's very, very different strategies. Very, very different approach, which I suspect will have different results. And one thing that will be interesting is to see how the president is going to be able to square the circle of guaranteed access with a commitment to cover everybody with better benefits at lower cost. Because channeling President Obama for just a second, if he can do that, that would be great. We ought to do it. We should repeal the ACA and implement that new plan. Suspect that's not going to be as easy maybe as it sounds. Jacob had talked a bit about FDR, and his cousin, Teddy Roosevelt, is largely credited with one of the first, at least platform positions for having universal health care. Not when he was president, but when he ran in 2012 as part of the Progressive Party. And his platform read that he proposed the protection of home life against the hazards of sickness, irregular employment, and old age through adoption of a system of social insurance adopted for American use. Now, he lost to Woodrow Wilson, so maybe that platform position didn't work out as well. But that's, in part, one of the first initial efforts. We've already heard about FDR. He was thinking of putting this in originally in 1935. He did pull it out, as Jacob had said. And I think he did it in part, and tell me if I got this wrong, he didn't think the rest of it would pass. Is that? Yeah, yeah.
And he had his personal physician was very much against it.
Is that, so he was getting lobbying against it? So everybody don't care. All right. Well, there you go. That would make it typical then. So the Republican congressional win in 1946 pretty much derailed some of Truman's attempts to try to do the same. So there've been these consistent attempts. Johnson, of course, in 1965 passed the Medicare and Medicaid legislation. I do want to put a little plug in for Jacob for a second when he was talking about the public option. This public option issue is probably more maybe profound as you might actually think. It's something that we talked a lot about with the president. He was a big fan of that. As a matter of fact, he wrote an article, which you may have seen. I believe it was in JAMA, talking about where he thought good options for giving people more choice, particularly in rural areas. And he raised the public option as that approach. We were very big fans of seeing what we could do to promote the public option, and really thought that was the right approach. Again, I'm getting a little off my paper here, but as you probably know, the co-op program came to replace the public option. The co-op program is actually not as bad as it often got credited for being because so many went out of business. They went out of business for a lot of reasons. One is because they didn't get risk corridor money, one of the 3 R's. And the second is because the leadership, usually in the management, was not very good. But it in no way was going to be as impactful as what the public option would have been. That was the right solution. That really was the right approach. And we tried to figure out ways we could resurrect that. Nixon, I think, as many of you know, was also rather engaged in healthcare. He and Ted Kennedy had almost a bit of a competition as to who could have the more robust program. He, of course, was responsible for the HMO Acts of 1973 and 1974. So in a lot of ways, when we see health maintenance organizations, they in a lot of ways date back to those acts. Ted Kennedy told us when we were back in Massachusetts before he died that the greatest regret of his legislative career was that he didn't compromise with Nixon. And he thought that was the big, and when he looks back, he said, that was my big opportunity. And he said, I held out because I was a purist. And he said, in retrospect, he said, I made a mistake. We could have done something more. But that's part of politics. Of course, President Clinton had his initiative, and of course, Hillary is mostly associated with that in 1992 and 1993. A really good example, in some ways, of how not to do something. Not because there weren't very good and smart people doing behind it, but because it was done in sort of a secretive way, did not engage a lot of key stakeholders. When you've got something, what is now 18% of the GDP, those stakeholders want to be engaged. And I think to the president's credit, that was something that was a learning going into the late 2008, 2009. A very good book, by the way, is David Blumenthal's Heart of Power, in the Oval Office, which relates to some of the history of presidential attempts to try to provide health care. The genesis, as Jacob said, of the Affordable Care Act really is Chapter 58 in Massachusetts, which was the enabling legislation setting up the Health Connector. And it provided the most robust state initiative to provide health care access that had ever been done before. Massachusetts, by the way, prides itself on those kinds of things. But even so, the politics behind that were very bad. And at one point, because it was a Romney bill, the Democratic leadership was going to stonewall that and was not going to sign off. And Ted Kennedy actually had to get engaged and broker the deal to get the legislation passed. It was a very significant thing. But one of the things that I think was challenging about the Affordable Care Act, even though it was built so much upon what was done in Massachusetts, is that Massachusetts had made a number of reforms years earlier. So in 1997, a number of reforms with respect to either guaranteed issue, a 2-to-1 age band, which meant that older people couldn't be rated more than 2 times what a younger person could be. That became the genesis of the 3-to-1 in the ACA. Women couldn't be charged double, men, no lifetime limits, that kind of stuff. That had actually been introduced, community rating, back in 1997. My point in raising that is that the market, the insurance companies, had adjusted to those underwriting rules by the time Chapter 58 came about. In contrast, the Affordable Care Act actually put all that stuff in at once on a strike date. I think a learning, if we could have done things differently, would have been to actually phase those things in, to get the industry to get used to the underwriting and the actuarial and the experience on an incremental basis. Having so much change at once was very, very challenging for a lot of the companies. And again, you could see why it was done, because the politics was that if we don't get it in now, we won't get it in at all. But from a practical perspective, that could become very difficult. Issues driving Chapter 58, by the way, were a number of things. One was the expiration of a Medicaid waiver, which was impacting thousands and thousands of people if that didn't get resolved. The second, and these were actually a big issue for the governor, by the way, was a perceived overuse and misuse of the emergency room. And the second was a underfunding of the state's uncompensated care pool. The governor was very strong about saying, I think people are abusing the system, and we've got, he didn't say it this way, he was more eloquent than this, but he basically said we've got freeloaders in the system. That's what he meant by the uncompensated care pool. And he really liked Stuart Butler's mandate idea, which, you know, the Affordable Care Act's genesis really is from the American Enterprise Institute in reaction to Hillary Care. No, I'm sorry, it was the Heritage Foundation, not AEI, thank you. It was Heritage, which is one of the reasons, I think, that replacing the ACA is so challenging, because the ACA really is the replacement. That's the Republican replacement plan. So it's hard to replace a replacement. Large employers were beginning to really tighten eligibility, so more and more part-time workers were losing coverage and were able to get the hours necessary to actually be considered full-time employees. So all these things together were big, big drivers, but the governor had a very, and we talk about leadership, again, this came from the governor. The governor had a very strong perspective that the system was being abused, that there were some freeloading going on, that if people didn't want health care and they weren't going to buy insurance, he didn't put it this way, but his implication was they should sign some kind of waiver that said if they were really, really sick, they wouldn't get coverage. Now, of course, you wouldn't do that, and there are federal laws that prevent that. But that was his tone, which is that this is a responsibility. So he really liked Butler's mandate idea. So that's how things came about. The parallels to the Affordable Care Act include the following. A is the expansion of Medicaid eligibility. The second is income-based premium subsidies. The third is allowing kids to stay on their parents' plan until age 26. There was an interesting competition going on between states on that one provision. So, for example, Massachusetts got all this publicity for allowing children to stay on their parents' plan to age 26. Well, about, I can't remember if it was a year or 18 months later, Florida jumped in, but expanded that to age 30. And not to be outdone, New Jersey expanded it to age 31. So up to age 31 in New Jersey, you could still be on your parents' plan, which created all kinds of jokes about the motivation of kids in New Jersey to leave their parents' basement. No lifetime or plan caps, no pre-existing conditions. This issue on pre-ex has been probably the most potent of all. Roughly 27% of enrollees in the ACA had pre-existing conditions. So it's not an insignificant number of people. And it's also something that's just spanned income, wealth, gender. It didn't matter. I've probably done over 100 town hall meetings, including a lot in Connecticut. And I remember very well thinking, going into a meeting in my first one in one of the wealthiest Connecticut towns in Darien, that it was in a public library, and I just, for some reason, felt it was going to be really hostile, and I'd be viewed as a communist or some kind of terrible thing. It was just the opposite. There must have been 40 people that waited at the end of the presentation to talk about their individual situations. Either their husband wouldn't leave his job because if he did, he couldn't get insurance. Their child had cancer. I mean, these stories went on and on and on. That was true in Greenwich. It was true in Westport. It didn't matter. And it's something, when you think about that, you think about age 26, the no lifetime caps, also women not being charged double men, which was the case in Connecticut, by the way. Those are favorable irrespective of ideology. So the most conservative Republicans think that those provisions need to be part of a new health care law. But the fact that they believe it is also the reasons it becomes so hard to make a change. Because, you may recall, President Trump has said, cover everybody, better benefits, cheaper, no pre-X, kids to 26. That's all great, and good for him for saying it. But it boxes you in from a policy perspective in terms of how much more you can do. So anyway, those were all things that were all part of the Massachusetts experience. SHOP, the small business program, we piloted that. It was about as successful in Massachusetts as it was nationally, by the way. The metal tiers, for the little cocktail footnote, the metal tiers were actually named by my wife. I was in charge of creating these names for tiers in Massachusetts. For some weird reason, I was trying to do it on this Revolutionary War theme, so I had the Freedom Plan, the Liberty Plan, the Constitution Plan. I used to run them by my wife before he went to sleep. She said, that's a bad idea, that's a worse idea. And one night she said, why don't you just name it after the Olympics? Gold, silver, bronze. Everybody knows what that means. So that's been her contribution to health reform. Issuer choices and innovative marketing and outreach was also a critical part. So implementation. So implementation in Massachusetts it turned out well. It's like making sausage. It wasn't that great during the time. In part, it was because that after the law was passed, the executive director was hired in June. Most of the key staff was hired in place by August. And we had to have the Commonwealth Care Program, which was the Medicaid expansion piece, up and running by October. So we had 2 months to get the first big piece, which also involved the highest number of impacted citizens in the state, residents in the state, up in 2 months. So that was tough. Fortunately, we had a pretty good relationship with Mass Health, which was the Medicaid group. That relationship subsequently eroded, but at the time it was pretty good, and we were able to get that up. Commonwealth Choice, which was the exchange piece, had to be up 9 months later, July 1st. That also was a very, very brutal thing to do, in part because we over-engineered. I think that gets very typical as people try to, you want to do the right thing, and your vendor talks you into doing all kinds of different cool things. In retrospect, we probably could have bought some of this functionality from some other vendors instead of having to build it ourselves. But we chose to build it ourselves, and again, it worked. But it worked with a lot of pain to get there. And then when we ever had to make a change, it turns out that the technology had all been hardwired, which means it wasn't easy to replace or tweak. So again, it's things you learn. Organizationally, we learned a good lesson there, and this also gets to leadership. Roughly half the staff at the Connector in Massachusetts came from private industry, particularly the insurance industry. The other half were state employees. I say that because what I learned in Massachusetts and what I brought to the implementation in Connecticut was a sense that when you were really under the gun, when you did not have a lot of time, that having people that knew the industry was incredibly helpful. The insurance industry, the health insurance industry, is like many other industries. It's very quirky. And people in the health insurance industry have this sense that if you don't come from that industry, you really don't understand. And I've heard that expression from CEOs for years and years. Well, you don't really understand. It's, you think you do, but you really don't. So for hiring people that came from the industry, had credibility with the issuers, and we were then able to talk about policies and administrative procedures, also operational issues that really expedited our ability to build our functionality. Another thing we did, and this is something that we did in Connecticut that was a learning from Massachusetts, is we brought the insurance companies in and said, would you help us design the processes? So for example, there's these very, very detailed IT data transfer requirements and specs that need to be created. Instead of going to them and saying, this is what the rules are going to be, these are going to be the new requirements, we had them come in and say, help us build this. So we would show them a schematic, and we would say, can this be done easier? And I remember this table that we had in Hartford, and the insurance company said, well, step 3, you could consolidate 3 and 6. And then you see 9, how about 9 and 11? That could get compressed. And what it did was, A, it made our implementation better, our processes were more efficient, but B is it got them in the boat. Because they were helping us design, they were then committed to its success. So a lot of it was just getting their organizational buy-in to say, if you're helping design it, guess what? You're going to help us succeed. So that was also something that we had learned. And as I said before, this is no knock on government workers. It was just that given what we needed to do with the time frame we had, this is what made the most sense. A second key learning that came out of Massachusetts that we also applied in Connecticut and also tried to do on the federal level was the importance of communication and outreach and stakeholder engagement. One of the things that has to be done, and I don't think we did this as well as we should have at Healthcare.Gov, is this program has to be continuously marketed. There's an enrollment period, which is an open enrollment, and there usually you've got television ads or you've got PR going and you've got advocates speaking on your behalf, third-party advocates and such. But it's a 12-month-a-year job. And I think one of the things that the White House in particular did not want to do I'll reverse that statement. There was almost a sense of once it was passed, leave it alone. Don't disturb it. You might stir up the dog. You might get people concerned or ruffled. Just implement it and it'll take care of itself. I believe, again, going back to leadership, that was a mistake. We should have been more aggressive about continually saying this is the value proposition. Look how many people with pre-existing conditions are now covered. Look at Johnny in Knoxville who had cancer, now has got coverage. Just constantly reiterating value, proof statement, this is working. Because just speaking personally, one of the challenges I find, and I've talked to some of the Democratic leadership about this is, and I'm going to touch on this in just a second, is Republicans are being very, very good about sticking to talking points. It's a disaster. It's going into a death spiral. The deductibles and premiums are unaffordable. There's like these solid talking points that are said every single time. I don't know about you, I don't hear a comeback to that. I don't hear anybody giving another perspective. I don't hear Democrats saying, wait a minute, you're wrong about this. These are 5 reasons. So my point is that when you're implementing something from a leadership perspective, think about continuous marketing in a way. Communicating, saying, here is the value, these are the metrics that we've established, and let's show you how the metrics are working. A third element of learning is transparency. One of the things we tried to do in Connecticut to greater or lesser degrees was to communicate when we were doing well, but also communicate when when something wasn't working. And that was very deliberate because A is we felt people needed to know, but B is it bought us the credibility when things were working. It's so rare in a public program that someone will say, you know what, we missed this mark, or that deadline got missed. Or yeah, we were supposed to do 92% of these transactions within 5 working days, and we hit 81. But when you say that to the press, when you say that to a group of folks such as yourselves, the fact that you're actually admitting that something didn't work, A, is surprising. People don't expect it from a federal official. But number 2 is it buys you so much credibility on the things that do work. The press in particular found it extraordinary that we would actually admit mistakes. So that was something the White House was highly uncomfortable with. Matter of fact, this was a personal issue. I was so used to a certain style of talking when I was in Connecticut that I tried that when I was down there. And I was told right away, someone from the White House called and said, Kevin, remember, you are not the news. Do not make news. I said, well, is that code for don't be honest? They said, that's not how we see it. So they had their own way of doing things. But there's nothing wrong with that. Fourth learning is vendor management. Again, I'm getting a little operational here, but managing vendors is just incredibly important and incredibly challenging in these big kinds of technology build. Again, an example, let's put that in context for leadership for a second. Again, I apologize to go back to Connecticut, but it was a fairly recent experience. CMS and HHS kept changing deadlines and adding policies back in 2013. Many of us felt that the goalposts kept getting moved to the point where it became difficult for our IT vendors to actually know what to deliver at what time. So at one point in March, I called the administrator of CMS. And I said to her, I just want you to know something. that you can make any policy change you want. You can change any deadline you want, and that would be great, and wish you all the best. But as of March 31st, we're locking our system down. So anything you change after March 31st, we're not doing. Now, we can do it a year later, but we're not doing it for October. So she got a little energized over that. And I said to her, look, call the governor, fire me, do anything you want. I'm just letting you know that we are locking down on the 31st. A week later, she called back and said, I think maybe that was a smart thing to do. And one of the challenges with open enrollment for Healthcare.Gov was they didn't lock down in time. They always kept moving the goalpost. Their IT vendor constantly had to rework their specs and rework that deliverable to accommodate this new deadline. And all my point is, from a leadership perspective, is you sometimes do have to jump in those waters, make that decision because you know it's right, and you stick with it. Because if you are decisive about things like that, you'll be surprised how many people will follow you, because they're all afraid something won't work. In Open Enrollment 1 for Healthcare.Gov, people did not speak truth to power. I mean, to be very, very frank. As a matter of fact, it was almost worse than that. There was almost a deception. So, for example, 2 weeks before the launch, which was October 1st of 2013, there was an extremely high-level meeting with White House people, CMS and HHS people. The system was supposed to be demoed, right? So that's where you literally would go on, you put in your information, your name, zip code, family size, income, things like that. The demonstration was done with wireframes. Wireframes are PowerPoint slides, but they were sequenced to make it look like it was live. And people said it was live. It wasn't live. That's a fireable type of moment. More people should have had their jobs terminated for that. But that being said, I haven't said this to him, and I wouldn't. But in a way, if this was my signature bit of legislation and I were the president, I would have asked for a laptop, the URL, and say, I'm going to take an hour and I'm going to go on this thing before we launch and see if this thing works. And I would just tell you, from a leadership perspective, whenever you're running a big project, you can have the best faith in your folks. You got the greatest people. You trust them, high integrity. They never let you down. But before you go on something, do it yourself. Nobody else in that room. No one's talking to you. Because if you can't do it, your customer can't do it. I had to do that in Connecticut. I just remember saying, guys, great, love you. You're terrific. Get out. I want to do this myself. At some point, you just got to be hands-on yourself. So, and someone should have told the president, someone should have told others that this was not going to work. Because I think if that were done, that perhaps it would have been delayed, and that whole embarrassment of that open enrollment. Do you know how many people they enrolled the first day, nationally? 2. So think about that in a 24-hour period. 2 people were able to get through. That's not what you want to do. So anyway, just something to think about, again, from a leadership perspective. I think I talked a little bit about how the 9 titles of the Affordable Care Act. Title I, of course, is ultimately really the one that we most think about, with exchanges, about Medicaid expansion, things of that sort. I mentioned about the implementation of the Affordable Care Act, which could have been done differently. And again, when you think about yourself as leaders, and you think about yourself being in that type of position, learn from these kinds of lessons. One of the things that we did in going into the second year was actually re-engineer so much of what was done. The vendor for Healthcare.Gov, in my view, I believe, got an almost unfair amount of blame for the failure of the system. Yeah, if you're a vendor, yeah, you bet. You're getting paid for it. If it's not working, you always take the blame. But you have to manage that vendor. I'll just give you just a quick example. In January of 2013, going back to our state of Connecticut, I remember sitting with a couple of guys with our vendor saying we didn't think that they were going to be able to deliver on what they said they were going to do by open enrollment. They, of course, disputed that, gave a bunch of good reasons. We said to them, guys, we respect you. Thank you for all that. But we want you to know that we want you to cut back 30% of what you're going to deliver. No, that's a big mistake. This is the reason you're not going to be able to do it. You're going to regret it. Yes. Okay, maybe. But I remember saying, we want a Ford Focus and not a Cadillac. We want the car. We'll put the CD player in later. The electric windows, we don't care about that right now. We want the engine, the transmission. We want the wheel and the tires. The doors, forget everything else. And when we talk about the Connecticut Exchange working, that's fundamentally why. It got stripped back to a lot of the basics. And that's really what Healthcare.Gov should have done. Ironically, that's what Massachusetts should have done when it got relaunched, because Massachusetts wanted to show the country that it could do everything. It could have integrated eligibility, it could include TANF and SNAP and all these other state programs, and they couldn't. So leadership, management, manage your vendor, but also always be conservative and plan for more time than you think. That lockdown of that system on March 31st in Massachusetts, in Connecticut, technically we would have been able to launch on September 1st instead of October 1st. That would have been great, right? Well, that's, another month of time. Turns out on September 23rd, one of our board members got very upset about the way the plan benefits were being displayed. She insisted, she was the commissioner of the DOI, Division of Insurance, that we redisplay our plans differently. And we had essentially 7 days to do it. If we didn't have that extra time, that fudge factor, we never could have made that change. So again, when you're thinking about leading teams, always build in fudge factor, because something's always going to happen to you. Talk a little bit about results. So you listen to the talking points against the Affordable Care Act. There are a couple kinds of things, and one is that the Affordable Care Act is collapsing and it's in a death spiral. I would tell you that based on my experience, which ran through January, that I actually think the opposite was true. Our enrollment was ahead of where we were from open enrollment 3. The mix of our lives was actually trending towards being younger. The issuers were actually beginning to make more money. This thing about issuers all losing money, by the way, is a complete myth. Now, they were not all making money. It was roughly 35% were profitable. But we met with 25 of them over the past 2 years to understand the key success factors of why some were working and profitable and some the others weren't. And they all ran, the profitable ones, successful ones, all clustered in the same group of different cohorts. For example, they had strong leadership. The CEO in every successful issuer made a commitment early on to the whole staff of the employees that said, we are going to win, we are going to be successful, the individual market is the future, and we're going to prove to everybody that we can do this. So there was already a statement from the start. The second was they looked at their enrollment as being more like a Medicaid population than a commercial population. As some of you may know, the Congressional Budget Office had projected that the small group market was essentially going to go away under the Affordable Care Act. And when they were projecting those 23, 27 million enrollees, they were essentially assuming that that entire market of lives of 50 and under in the small group market was going to go away, and they were all going to go into the exchange. Well, that did not happen. And again, this is no fault. There's no heroes or villains here. But a number of the very large carriers made their actuarial, service, communication, medical management assumptions, assuming the population would be like a small group population. In fact, it was much more like a Medicaid population. So the ones that were most successful were the ones that treated that population differently and didn't take a one-size-fits-all approach in those key things. And I'll just give you an example of one. So Horizon Blue Cross does something very interesting with their enrollment card. So if you enroll in Horizon Blue Cross on the exchange, you get an enrollment kit, as you would for any other enrollee. You get an ID card, but the ID card is like a credit card, meaning you have to call the call center of Horizon Blue Cross to activate that enrollment card. When you call, the customer service representative takes a health risk assessment about you over the phone. So they've got an HRA for every one of their enrollees right away. They then ask, do you have a doctor? And for those that don't, they're assigned a primary care physician right on the spot. And they're scheduled an appointment while they're still on the call. Because it goes back to something that Mario Molina said, Mario Molina from Molina Health last summer. And I didn't really get what he was saying. I said, what's the key to your success? He said, get him to the doctor. And that seems so flip and coy, but what he meant was that the earlier you get people in, the earlier you understand their health condition, the earlier you understand if they've got complex care that needs to be medically managed. So what Horizon does is take these new enrollees that don't have doctors, and even the ones that do, they get them scheduled right away, and they begin a risk stratification. So that doctor comes back and says, you know what? David Jones looks like there's this risk for this type of chronic illness. And they get a nurse or a case manager involved right away. The less successful carriers wait to get either claim data or pharmacy data in, and then they employ a medical manager. Or they send a web link and say, here's our, you looks like you have diabetes, here's our diabetes program. Well, how many people do you think actively enroll in a diabetes program? Not that many. So it's a pull strategy versus a push. And it's been much more successful, and it's worked for them, and it's also being replicated. Florida Blue Cross, makes a 5% after-tax margin on their enrollees. Their CEO, who's a good guy, he likes like total domination of enrollment in the state of Florida. 2 carriers, as you know, left Florida. United and Aetna pulled out last year. And they together had about 400,000 lives. We worked with the insurance commissioner. He wanted 100% of the enrollment. He ended up getting 82%, and he was mad. So when all I hear about the people saying these insurance companies don't want this enrollment, this is all bad, they're all losing a ton of money, it's just not true. What is true is that there's the people that know how to manage care and understand this population are successful and typically profitable. Those that don't know how to manage care, treat it like their group population, they aren't. So it's not a huge surprise sometimes when you see certain carriers drop out of the market, because they're actually not very good at the individual market. They don't really understand it. They really don't like it. And they really should do something else. So that's not really a bad thing, but it gets positioned as if it were. The second thing about the death spiral, of course, is 85% of our enrollees are subject to subsidies. And the subsidies essentially hold them harmless because they increase with rate increases. Now, that being said, we cared about everybody. So those 15% that didn't get subsidies, and they got hit, say, in Oklahoma with a 55% rate increase, that did not feel good. That did not feel good at all. And I would tell you, the insurance company in that state also runs plans, Blue Cross plans in 4 other states. They lost $1.5 billion in part because they didn't get their risk corridor money. And so they were making up for this loss in every possible way. As a matter of fact, they put Zika loads in as part of their renewal rates for 2017. Now, last time I looked, if you were in the state of Illinois, the risk of you getting Zika was fairly minimal. But there was a 2.7% Zika load in those rates. And as much as we tried to talk the CEO out of that, she held pretty tough, and that was maintained. But that was true in each of the 5 states. So it was like belts and suspenders. So anyway, this whole idea about everything going into a death spiral is untrue. It's also been disproved by the Council of Economic Advisors and Brookings. A second is that premiums have skyrocketed. That's definitely true in some states, but it's very much bifurcated. So for example, if you're in Ohio, the rates actually dropped by 2%. If you were in Florida, they went up by about 12%. It's not low, but it's not the 22% or the 50% that gets quoted. New Jersey was around 7, Michigan was around 5. So it's just an extreme overstatement to say that the rates have gone up everywhere. Part of the big challenge has been that the insurance companies, to their credit, many of them admitted that they lowballed going into the early rates because they, for some crazy reason, they thought that the law would actually be made good on, so that they would get all the 3R money, the reinsurance, the risk corridors, and the risk adjustment. They did not get the risk corridor money. They should have gotten it. It's now being, of course, subject to lawsuits. And the insurance company that most recently sued won. So we'll see again how that plays out. Issuers are fleeing the exchange. That's not true. There's a segment of issuers, the ones that don't know the individual market that are. But the ones that do, like the big Blue Cross plans, have often expanded. Oscar, in fact, which is a plan in New York that's still sort of getting its legs, they've expanded, going up from Los Angeles into San Francisco. So again, we're 4 years into it. This is a 5-year implementation. It's just a bit early to draw a lot of these kinds of inferences. So finally, let me just talk a little bit about the repeal and replace. You know, there are roughly 5 bills, I think, that have been out. There's the Price bill, the Upton bill, it's Paul Ryan's Better Way bill, and I've not read the most current one that came from Rand Paul. But they do seem to have a couple of things in common. One is the use of high-risk pools to sort of take chronically ill people out and put them into a separate pool. A second is the deployment of health savings accounts. Just a couple of things on that. My personal experience with high-risk pools is they tend not to work all that well in that they tend to be underfunded. That was true in Massachusetts, which was one of the reasons that Romney introduced Chapter 58. It was certainly true in Connecticut, where the loss ratio became about 1,500%, and that literally was in a death spiral. And there was never quite enough money, and so the benefits kept getting cut. So this idea about getting better care, better coverage for less money, may be true if you're healthy, may be true if you're younger, but if you've got some chronic illnesses, or God forbid, a really serious one, and you're put into a high-risk pool, it tends not to work that way. The second is health savings accounts are great. Typically, they benefit people that are higher income because they are able to use the tax advantage element of those plans. Again, if you look at the profile of most of our enrollees, we have 70% of our folks are under 200% of the federal poverty level. If you go up between 250 and 3, and then 350, we had roughly 6% of those eligibles. It's very much targeted around lower income people. How they necessarily benefit from health savings accounts is unclear. But those seem to be very common themes. So in a way, it strikes me that we're moving into what could be called the 401k-ing of health benefits. If you look at vouchers for Medicare, if you look at block granting for Medicaid, and if you look at this prospect of health savings accounts and high-risk pools, it's essentially like in the pension business, giving a defined contribution, like in your 401k. Here's a bunch of money. This is all you're getting. Do with it what you will, and good luck to you. That's a good, legitimate debate that we should have as a society, but it's a radical difference from what we've been doing before, and also what the president committed to on the campaign trail. So I think it's going to be very, very exciting to see what goes on. You know, I think that, you know, the atmosphere is is not very conducive to cooperation. The Democratic strategy right now seems to be to let the Republicans kind of twist slowly in the wind on their proposals, let them kind of blow up between the House and the Senate, and watch from the sidelines. That may be the right approach. I'm not sure. It doesn't strike me as necessarily the most constructive approach. I would hope, perhaps, that you could take leaders like a Chris Murphy in Connecticut, a Ben Sass, a Republican from Nebraska, a guy that used to run OMB, get guys like that together, really think thoughtfully about what our options should be, and think then about planning strategically as opposed to letting this constantly be a political battle. The reality is, guys, that healthcare is far too important, not just to us in this room, but to millions and millions of our fellow citizens, to continually to be subject to ideological and political whims. And it's just not the right battle to have with healthcare. You can have it on some things, but healthcare should not be that one. And hopefully what we're going to do as we mature as a society, we mature, now that we have an installed base of over 22 million people that are subject to the law, both between Medicaid expansion and between the exchanges, that we come together and look for some common solutions. I'm really encouraged, hopefully that will be the case. I think if we were 3 or 4 years ago when nobody was enrolled in this, it was something different. But if you look at Trump's base, it's age 45 to 60, typically lower income, a little lower educated. Those are the folks benefiting most from the Affordable Care Act. So, thanks so much for your patience.
Food, and so I want to be brief, but I also think it'd be great to have a dialogue with Kevin about this important topic, and I really appreciated his remarks. And there may not be heroes and villains, but there are certainly heroes, and Kevin is one of them. And he didn't mention, I think, you know, if you had asked me 10 years ago when I was finishing up this book entitled The Great Risk Shift, about the way in which we were seeing this move towards a 401k world in health insurance after we had seen a move to a 401k world in pensions. If you had told me that we would have cut the uninsured rate in half without spiking healthcare costs, I would have been very skeptical, let us say. So I think you understand. I mean, you're right that it's good to be candid about the shortcomings, but it's also, I think, important to acknowledge why this is so difficult. That the very challenge that made it difficult to do this in the first place, namely that lots of people depended on private health insurance for their employers, is now a problem for Republicans, because lots of people now have come to depend on the expanded Medicaid coverage and the coverage they're getting through the exchanges. And you know, I think in this case, this fight, you say exciting, I think it's perhaps exciting in the way a horror movie is exciting, but I'm interested to see what people here have to say. I have this mic because we're recording this, so if you have a question, just raise your hand, I'll bring it to you, and you can ask Kevin a question. So over here, yeah. I'm afraid so.
Hi. So my name is Amy. I am the master student in the healthcare management program here. So I have a question. One of the purpose of the exchange is to encourage competition.
Yes.
Is that to get a lot of insurers, issuers to join in. But the thing is, like, it has been designed in a way that make it the small issuers very hard to compete. What you said make a lot of sense, and that's what they should have done. But when the law was passed and when they have to get on the exchange and selling that product, nobody necessarily understand the population that they have to enroll, they have to serve, and also from the risk management perspective, it's still very difficult for them to even know about it. So I know for that purpose, for that reason, a lot of co-op and a lot of small issuers, and after being hit with the risk corridor and risk adjustment, paying back and everything, it's causing a lot of them to either went out of business or decide not to continue on the exchange anymore. And I just want to really hear your thought and comment on that.
It's a very good question. And you need to forgive me, and the audience too, please. I'm going to get a little technical with you for a second, so forgive me.
He wasn't being technical up till now.
Yeah, right, exactly. I'm sorry. That's right. Sorry. It's been too recent. The question that you've raised has been a very common question that's been surfaced, particularly from smaller companies. You mentioned the co-ops, absolutely. You mentioned smaller companies, that's absolutely true. But I think it's actually more nuanced than that, and I'll just give you a quick example. I talked about that segment of issuers that have typically been successful and profitable. They almost all did about a year's worth of market research into the exchange population in terms of morbidity, in terms of communication style, in terms of demographics. They did a lot of analysis, and they often designed networks and medical management and talked about and contracting elements with their providers based around this new population. Those smaller companies and carriers and the co-ops typically did not do that. Now, that's not knocking anybody. It's just saying that sometimes that research wasn't done. In retrospect, I think, a lesson learned, right? Leadership. I think we should have done a better job of understanding that ourselves and disseminating that information to all the issuers. We were very much in this second year, that when I came in, of this mindset that this is the free market, these are the insurance companies, it's not our problem, it's their problem to manage their business, they don't want us in their business, so we just do our policies and procedures, and we'll leave the market to work. That was a mistake. This was new to everybody. And I think, again, in retrospect, we should have done more idea sharing. We did it subsequently over the last 6 months, and we've actually created a toolkit that we've sent out to every CEO now on these lessons learned about the successful issuers, and what's worked and what hasn't worked. We should have done that earlier. And now I'm going to get technical even more. And this is going to sound very partisan. It's not meant to. But in 2015, with the Budget Act that the Republican sponsored that changed the rules around risk corridor funding and made it revenue neutral, that I don't know if they knew what they were doing, but that was probably the smartest way to derail the Affordable Care Act that they could do, because it took out billions of dollars of funding. And it's so interesting, they really didn't get blamed for it. We got blamed for it by the insurance companies. It was amazing. I remember the CEOs would come in and they were like screaming and pointing their finger and you look what you did. And it was like we were responsible for not getting the legislation killed. So again, not trying to get in that battle, that was a big one. A second one was risk adjustment. The more successful issuers had their actuaries get involved early on, making sure that claims got coded properly, that they knew what providers were doing, that the codes were properly done. If you look at United Healthcare, in almost all their markets, they made more money off risk adjustment than they did on underwriting gains because their data mining was so rich. These small companies don't usually have those resources. So again, a lesson learned, leadership. Not only should we have disseminated market profile better, we should have disseminated how to manage risk adjustment better.
That's great. Another question? Any other questions? Yes. Hi. Right here.
Can you talk a little bit about one of Mr. Trump's proposals to do with selling insurance between states, with a mind to the fact that some of those in the audience are not from the U.S., and so a brief explanation of what I'm talking about.
Okay, very good question. This question has to do with the selling across state lines. And for those of you that were not from the U.S., one of the things that President Trump did during the campaign was very much underscore this idea that, you know what, the big problem is that we're not doing enough to make it easy for people in Maryland to buy from a plan in South Dakota. And if we did that, you know, this would be, the plans would be more competitive and thus prices would come down. Way oversimplified. But this is the dynamic around that. Each state in the United States has a Department of Insurance, and that Department of Insurance regulates the insurance companies and also administers what are called mandated benefits. Connecticut has among the richest mandates in the country. If it's not number one, it's definitely in the top 5. There are roughly, at least when I was here 3 years ago, there were 63 mandates. And what tends to happen, and this is not meant to be, this is going to sound insensitive, it's not meant to. What often happens at the legislature is an interest group will come in and say, you know, there's this disease called X, and there are Y number of people that are impacted by that. They're not able to get coverage right now because the carriers don't provide it. And this is providing this kind of financial hardship to both the child and the parents. Should you not, legislature, include that coverage? Well, that just stacks up, it stacks up, it stacks up. And that can add actually a lot to the premium. Now in Connecticut, it used to be about 15% that all the mandates added on when you look at all 63, right? Incrementally, they're all small, but you put them all together. Part of what this idea is actually to say, let's encourage people to buy from the state with the fewest number of mandates, which I think is South Dakota. And if you use a credit card analogy, you'd almost be having regulators have a race to the bottom to say, we're going to offer the fewest number of regulations and mandates to make sure that most people buy from our state. I just don't think that idea has been thought through well. The NAIC, which is the National Association of Insurance Commissioners, as you might imagine, are very, very much against this concept. It sounds so simple. It's not simple to do. And it's got some potentially very negative consequences for enrollees. Healthcare costs are healthcare costs, right? Healthcare costs in South Dakota are going to be the same for everybody. Healthcare costs in Maryland are going to be the same. But it typically gets around those regulations and mandates. Is that responsive? Okay.
All right, I think we have time for one last question. Let's see, over here. Yes.
Okay, a related question. I think that the Affordable Care Act had something in the nature of a standard benefit package attached to it.
Yeah.
If that's true, you know, how much or how well did that add to it, and what's likely to happen to it, you know, under the modifications that'll be made?
Great. That's a very, very good question. Let me just try to put that question in context a little bit. And if I have this question wrong, please correct me. One of the things we introduced at Healthcare.Gov going into open enrollment 4 that began in November was this option of insurance companies to provide standardized benefits. And essentially what we did was to say to ourselves, and based on research, that we offer too many plans. We have markets in the country, counties, where we offer 147 different plan designs. Now, listen, the average person buying on our exchange, A, doesn't find health insurance that interesting. I know that's hard to believe, but they really don't wake up on a Saturday and say, I can't wait to get on that website. B is they find it intimidating and confusing. And then when they see 100 plan options, doesn't matter if they're in tears, they get overwhelmed. So what we wanted to do was basically say, if we were to standardize this, and basically say that from health plans A, B, and C, when you bought the silver plan, you're getting the same thing. And when you bought bronze, you're getting the same thing. And you bought gold, you're getting the same thing. That would make it easier for people to compare. The genesis of this, by the way, goes back to the connector in Massachusetts, where we introduced that about in 2009. And the enrollment went up by about 24%, in part because it was easier. The research showed, and again, this is going back almost 10 years now, that people wanted a matrix. They liked the bronze, silver, and gold. And they wanted low, medium, and high. So they wanted 9. And they wanted everybody to offer the same 9. So they could then know that the benefits were all going to be the same, and they could fix those. And then they could check price, they could check network, they could check service. We had pretty good, not everybody, but we had pretty good insurance company participation in the standardized benefits. I don't know what the final enrollment in the standardized plans have been. I've been trying to find out. And this is, I'm not knocking anybody. Information has subsequently become very, very hard to get out of CMS. Maybe it's just to me, but they're really kind of locking down on data. So that may be available at some point. But I think your question is actually spot on. To be very frank with you, this law is too complicated. It's got to be made a little bit simpler. I generally believe that the best thing for the Republicans to do is to build off what we have instead of trying to replace, because replacing is so complicated and it's politically incredibly risky. So we've got 4 years of experience to build on. We've got 22 million people in this program. We've got data. We've got data in this EDGE system. We've got claims data on every carrier in every county, 3,006 counties in the country. There's so much work that we could do to actually show what's working and what's not. But it does just harken to one last story, if you don't mind. If you ever file your taxes, you know that there's a form called a 1095 that you have to attach to it. And the genesis of this is the first year, we were sitting with the president, and he turned to the Secretary of the Treasury, Jack Lew, and he said, now, Jack, this tax filing for citizens, is this complicated? So Secretary Lew said, well, you know, Mr. President, every time you introduce something new, there's always a little bit of complication to it, but this is straightforward, this is simple, this is nothing that people can't do. So he turns to us and he goes, does anybody have a copy of that form? Now, I knew nobody wanted to give him a copy of that form. Now, because I've been around so long, I didn't care. I had a copy. And I said, I do. And a couple of people looked at me. They gave me a dirty look. So he looks at this form. He goes, we should have gone single payer.
Now we find out. All right. Well, thank you so much, Kevin. It is a complicated subject. I'm reminded of a perhaps apocryphal story about a time that Adlai Stevenson was reportedly giving a speech, and afterwards a woman came up to him and said, oh, Mr. Stevenson, that was the most wonderful, superfluous speech I've ever heard. and he was taken aback, but he thought he'd make light of it. He said, well, if you liked it so much, maybe I'll publish it posthumously. And she said, oh, yes, as soon as possible. So that was the most wonderful, superlative speech I've ever heard.
That's coming to mind.
Let's go and have some food. So thanks.
All right.